This lecture will be covering small n and single subject designs that are described in your book in chapter 12. So the chapter begins with an example of a single subject design, a study where we're looking at only one individual participant. Bisconer and colleagues in 2006 published a paper regarding this single subject treatment intervention and study. They were talking about a single patient at a facility, a patient with serious mental illness, including some really problematic behaviors that were, putting him at danger for injury and potential for injury for the staff. They were requiring a lot of interventions that were less than optimal, obviously, because they ethically, for what I'm getting at essentially is the use of restraints or the use of having to use medications to calm someone who's agitated. Those are things that you sort of want to try and do as a last resort in terms of keeping patients and staff safe. And in Sam's case, he was requiring a lot of these interventions very frequently and had a lot of potential self-injuring behavior as well. So the idea was, what can we do to try and modify his behavior in a way that keeps him safe and keeps us safe? And so this is a real world example, but they decided to study it in a scientific way. So they introduce a treatment plan with some systematic schemes for observing and tracking these behaviors, and then eventually seeing if they can intervene to try and change them. There is the idea that you can study an individual in a way that is scientific. I think that there's a misunderstanding in our discussion of how science practices, especially in psychology, that a true experiment is the only way to understand information in a scientific fashion, or that we need to have large sample sizes and huge groups so we can compare means and look at statistical significance. And that's all important, and that's all part of the process. But as is the case with quasi-experimental research or correlational research, I don't want to disparage the good name of, small n and single subject designs. We can utilize these types of designs in a scientific way that still has a lot of value for us within that framework. It's not just anecdotal. It's not just, individual stories about a person or a small group of people that you can't generalize at all about or can't learn anything about the larger population. So there are times when, as is the case with other types of tools in the toolkit, this is the appropriate tool. So the chapter is going to focus on telling you a little bit more about that intervention with Sam and how it went and what they utilized, and we're going to use it as an example to look at various different types of design. We're going to really give a good overview of all these different types of single subject designs. So, as I said, sort of in contrast with this idea of group designs, sometimes that doesn't always conform to practice, especially in the clinical settings. So when the practice involves interventions with individuals, which, generally speaking is clinical psychology, inpatient psychiatry, and that kind of thing, it also can involve some industrial organizational aspects of psychology, trying to alter people's behavior, intervene with people in sort of the workplace. But essentially, there's an argument to be made that by looking at large groups all the time, by looking at means, by looking at how people do on average or as a group, that perhaps we're losing some qualitative information about the individual that's really helpful and might be helping us to improve our understanding about whatever area of study we're looking at. So there's a large discussion in your book about how we're missing the individual experience with these larger group description models. And so a small n design is really an in-depth study of a single or a relatively few number of subjects under a tightly controlled condition experimentally. So the independent variable is manipulated often repeatedly over successive trials. In the simplest design, it's manipulated once, but there's lots of examples where you're going to see it manipulated multiple times, lots of pre-tests and post-test of the dependent variable as well. So some characteristics that we're going to associate with a small n design, this sort of type of research is repeated measurement of the dependent variable. So very atypical to see just one post-test. You'll almost always see at least a pre-test and a post-test. What you more commonly are going to see is multiple tests throughout the process, addition and removal of the intervention in a systematic way. So there's always a baseline phase. There's always a pre-test baseline phase. Then there'll be some sort of treatment phase where all subjects or the single subject are exposed to each phase of the intervention. So it's kind of, by its definition, it's a within subjects design. If you think about our previous discussion about group experimentation. And then finally, you will typically utilize graphic display to understand what's going on. Because if you think about it, almost all of our statistics, the inferential and descriptive statistics that we utilize up until this point in the class, all are regarding measurements of central tendency and variability. They're talking about groups and how those groups look in a mathematical sense. When you're looking at one person, three people, four people, what you find is that means are not necessarily as meaningful. They don't really have as much to tell us. It's the individual change and the individual representation of that change in a graph that helps us to see trends, understand how things moved or changed or were adjusted by our interventions or our manipulation of the independent variable. So repeated measurement, let's talk about each of those 4 points in a little more detail. In terms of repeated measurement, the target problem is often the way this is referred to, but whatever it is, it's the dependent variable, it's the outcome. The reason why it's sometimes labeled in this type of research the target problem is because the most common example of small n or single subject designs that you see are ones like that discussed in the chapter, like ones like SAM, where you have a treatment setting, it could be outpatient, could be inpatient, but you're trying to intervene on a specific problematic behavior or adjust it in a healthy fashion. And so the idea is that that target behavior, target problem is, in a sense, the dependent variable. It's the outcome we're trying to adjust. So we want to make measurements over a time course. You really don't see a cross-sectional single subject or small group design. It's much more likely to be longitudinal and look at things over time. So the idea is that you will almost always want to have what's called a baseline phase. This is our pre-testing phase. This is where we want to just sort of figure out what does the behavior look like right now before we've done anything. Let's establish a baseline. So during that baseline phase, the measurements are taken, the intervention is not offered to the subject at that point. Now, in some situations, it's not possible to get a baseline measurement because essentially you're dealing with something that's really immediate that needs to be done and addressed right away. It can be something like Sam, where it involves injuring, himself or someone else. Sorry about that. Let me turn this off. So the idea is that there may not be an ethical or a safe way to delay the intervention. But if you can, if there's a way to do that scientifically and ethically, then what you do is you want to establish a baseline. If you can't do that, what you'll sometimes see, especially with problematic behaviors that are often very well documented and closely tracked, especially in inpatient settings, you can go look at the nursing notes, you can look at the staff notes, and you can see they oftentimes in an inpatient setting, if there's any type of behavior like this, you have to document it within your notes, sometimes in a separate freestanding note. So that information is there. What you sometimes see if the intervention needs to happen right away is they will go back and retrospectively get some baseline measurement because they have that data available through the chart. So the measurement at the baseline phase, the sort of pretest, if you will, of the dependent variable, the target problem, whatever you want to call it, this establishes a kind of a within the subject's control group, where this is our comparison point that we're going to move forward from. And then repeated measurements of the dependent variable are taken until you can visualize a pattern. And we're going to talk about some examples of what patterns might look like coming up in just a minute. But if you think about it graphically, if we have 2 points of data, then we can establish a line. Now, 2 points is obviously inferior to 3, 4, 5, 6, 10, 12, 15. The more points of data you have, you increase what that line can then tell us. You increase the reliability, the consistency of the measurement, and you can potentially increase the validity of your argument that, hey, look, this behavior is going up or it's going down. You can talk about trends. If you think about it graphically, the more points on a line, or a line, I shouldn't say a line, the more points on a trend line, the more elegance it has, the more up and down ability, the more variability you see, the more you start to gather a more organic picture of what's happening rather than these sharp points that are made up by 2, 3 measurements. So repeated measurements allow us to see that trend appearing, and we'll talk about what those look like in a moment. You'll frequently see this baseline phase referred to as the A phase, because the way we describe these designs, we're going to get into this nomenclature of ABA or ABABA or ABCA or whatever. But the idea is that we often utilize letters to delineate the phases of the study. So the baseline phase, very classically referred to as the A phase. Then we move on to the B phase. And the B phase is the intervention or treatment phase. This is where you implement whatever it is that you're trying to do, and there are repeated measurements, again, of the dependent variable, the target problem throughout. There's common understanding, common wisdom in research that says that the intervention phase, this treatment phase, should be roughly as long, if not exactly as long, as the baseline phase. This has been recommended by lots of researchers. The idea is that you want to have equal proportions of time to allow for the problem to occur, or if you're going to compare these things, you want them to share certain characteristics and similarities, and one thing is you want them to be roughly the same amount of time. So you shouldn't have a super long baseline measurement and then a very short treatment measurement, or vice versa. Now, as I said before, sometimes the situation doesn't allow for a really long baseline phase. It's very brief, and so maybe the treatment's going to be brief as well. And then finally, we talked about graphing, which is this idea that you can really evaluate and monitor the impact of the intervention by what the line looks like. So virtually all small n single subject studies are going to utilize some graphic data display in their article. So let's talk about some trend lines here. These are pretty basic, but if you have two data points, and this is the target behavior measured here along the y-axis, and then along the x-axis here we have 1, 2, 3. These are just the days, right? So on a 2-day measurement, we've only got 2 data points. Now we can look at this and say, well, there is a slope to this line, but we have to be very careful about interpreting 2 points of data, especially a very small amount of data, because what we've essentially gone is from 6 to, looks like 8 or 9 here. Is 6 or 9 practically significant? Well, if I don't know exactly what it is we're talking about, then it's hard to say. So once we've established these 2 points of data, the line can do several things, right? The trend can continue, the trend can stabilize, and we get this sort of flattening out plateau effect, or the trend can start to disappear. So when you look at this with 3 points of data, do you see a pattern here? Well, that's very hard to say. It's difficult to interpret just those 3 points of data, which again is why multiple measurements of the dependent variable can be really helpful to recognize what's really going on if there's any change occurring. So we have to measure the targets of our intervention, right? These sometimes called the target problem, the target question, or in this case, we can think of it's the dependent variable, it's the outcome. So it can sometimes represent a larger problem, or sometimes there's multiple dependent variable measurements. So let's take the case of Sam, for example. In Sam's case, there were 3 behavioral measurements that were taken sequentially, and these all involved levels of aggression exhibited by Sam. If I remember correctly, I believe what they are is self-injuring behavior, so instances of Sam injuring himself, staff injury or staff assault, some sort of physical violence towards the staff. And then finally, I believe there was one that was use of antipsychotic medications due to agitation. So how many times did the attending physician say, this behavior is severe enough that he's going to hurt himself, he's going to hurt someone else, he needs to be sedated or given an antipsychotic. Sedation is kind of not quite the right medical term for what you utilize those meds for, but essentially an anti-agitation medication, which is what you typically use, is either typical or atypical antipsychotic medications, which have this sort of calming effect, especially if someone is feeling delusional or is hallucinating as well. So ultimately what's going on here is we want to look at those 3 aspects of the overall target problem, which is that Sam's behavior is unsafe in a variety of ways, because it's not healthy to be receiving lots and lots of doses of this medication every single day, multiple times a day, if need be, because that has side effects as well. So we've got to consider the health of the patient. What's the best way to do this? So they looked at those 3 dependent variable measurements. So you've got multiple targets that you're looking at, but they're part of a larger construct here. This is a good example we talked about in previous chapters. Multiple levels of measurement to get a better picture. If you just measured one thing, well, is that all that the staff is concerned about or the researchers are concerned about? I'm sure that the people working on Sam's treatment plan probably have issues of concern beyond just him injuring himself. They don't want him to injure the staff either. They don't want him to need to be given these sedating medications, multiple times a day. So they want to get a better picture of changing his overall behavior in the direction of being better for him, safer for the staff, and improving his quality of life. So they hit multiple measurements to get that larger picture. there's a set of metrics that I think is really helpful. So keeping in mind, you can measure these dependent variables simultaneously, sequentially. You can start and measure just one of them for a little while, move on to the next one, move on to the third one, or you can measure them all throughout the process. So simultaneous or sequential. As I said, there are four really helpful metrics for understanding behaviors. And this is something that goes beyond just single subject and small end designs. I think this is a really good way to think about any human behavior, especially if you're trying to examine change or relative, change over time. Um, I utilize this all the time with patients with PTSD. Um, there are extremely effective cognitive behavioral interventions for PTSD these days. It's one of those conditions that clinical psychologists have developed really effective treatments, but they are demanding treatments and they require a large commitment from the patient and a willingness to engage with that type of therapy. And it involves exposure to the trauma. And so, imagined and talking exposure about it. You spend a lot of time working through the events that contributed to the PTSD. Given that one of the major components of PTSD is avoidance, many of these patients choose not to engage with that therapy, or they, for one reason or another, are resistant to treatment. They don't have a good response to treatment, and it becomes chronic. And I see lots of patients with chronic untreated PTSD, essentially untreated PTSD by that metric. We talk a lot about what does it look like to get better? What does it look like to improve? Obviously the sort of essential human thing a lot of people feel is, well, I don't want to remember this at all. In a perfect world, you could Men in Black thing, wave across my face and I would forget the event altogether. We know that's not, realistic, especially such an emotionally charged, salient experience. What we can do is talk about your response and your reaction to that trauma, and as a result, how do your symptoms change? These are the metrics we look for. So, for example, to keep with this PTSD example, if you are having, very chronic, very troubling nightmares that wake you up, they interrupt your sleep, they contribute to other intrusive memories and flashbacks, either when you wake up or the next day. So these can be really problematic. If you're having them every night versus having them once a month, that's a useful metric, right? So that's frequency. How often does the behavior occur? And it can become really difficult if the behavior occurs like 20 times a day. If it's sort of a nervous tick, or it's something that happens really commonly, like smoking for heavy smokers, that gets a little difficult, because if the behavior is happening constantly, then you can't really get a meaningful measurement of it. Or if it happens really often, if it happens too rarely, that can also be a problem, right? If you're looking for a unicorn for a special occurrence that doesn't happen very often, you're going to have very few points of data and a lot of difficulty measuring any change. So frequency is a good metric to look at. How frequently does behavior occur? And with Sam, how often is he injuring himself? How often is he trying to injure the staff? How often is he requiring these, these injections, these medications, or oral medications? Duration. How long does the behavior last? So if the person is having a panic attack secondary to thinking about their traumatic event, how long does the panic attack last? If you're getting really good at coping with a panic attack and you're utilizing techniques like diaphragmatic breathing and relaxation to get through them a lot quicker and feel better, well then my panic attacks have gone from lasting typically 15 to 20 minutes. Now I can really shut them down quickly and they only last a few minutes. Okay, that's another example of duration of behavior. It's meaningful. Interval. How much time is between the episodes? This can be impractical, as I said, if it occurs really frequently, but you might say, I haven't had a flashback. I used to have flashbacks, or no, let's think about a different example. Let's talk about depression, because it makes a little more sense. If I'm feeling depressed, but I'm having a greater interval of good or euthymic, pleasant mood within those episodes of depression or dysphoria, then that's one way to see, like, I'm showing longer periods of remission from this symptom or this behavior. And then finally, magnitude, or you might also say, I frequently say intensity. So intensity is like, on a scale of 1 to 10, how bad is this thing? So the intensity. So when I have a flashback related to PTSD, if I'm a patient with that symptom, am I ruined for the rest of the day? Like, is it so bad that I have to withdraw and I feel too anxious to do anything? Or do I ride it out, get through it, utilize my coping skills, and it never really, I cut the peak off, right? I sort of soften the curve. It never goes to this incredibly high point. Well, that's intensity or magnitude. That's a really useful measure of behavior. So in Sam's case, if Sam is, you know, making a threatening gesture to the staff, but not attacking them, there's varying intensities of that behavior. If he is kind of like, scratching himself softly versus slapping himself hard in these self-injuring behaviors, well, that's an intensity versus maybe, hurting himself with an object. So there's lots of various different ways in which we can measure the intensity as well. So this is an example of the graph. Oh, I had it right. Use of restraints. It's use of restraints, staff injury, or needing of medications. The PM is medications, psychiatric meds. So 2 out of 3 is not bad, right? Anyway, so in this case, this is the frequency of the restricted behaviors after the intervention started. So in this case, you're not seeing the pretest data, and the reason why is because this was very serious behavior that was putting Sam at great risk. They pull the pretest data retrospectively based upon the nursing charts and what was going on that the staff had documented. So we've got use of restraints. I'm guessing, I don't know how many times a day this was being required. If that's the case, they must be using very extremely brief periods, which is kind of typical in psychiatric nursing. They don't put people in restraints for long periods of time at all. Then we have sort of staff injury. I'm guessing that these are rated on a different scale, or this frequency might be a little different than just single instances. But regardless, you've got restraints, you've got staff injury, and you've got use of these medications. And what you see is that these, oh no, 1-to-1, that's the one I'm forgetting, I'm sorry. 1-to-1 is how much was he requiring what's called 1-to-1 supervision, meaning was a staff member having to be detailed only to spend time with Sam? Was he being so unsafe that someone needed to be in his physical presence all the time, which you see sometimes with patients like Sam or suicidal patients for periods of, for brief episodes when they are really in great danger and need to be observed. So anyway, these are the 4 dependent variables we're looking at. And this baseline here is when day 0 is when the intervention was started. So you see all of these behaviors very quickly go down. There's some spikes here and there, but the general trend is quite good. So as I said, we got to measure our targets of intervention, and there are some special considerations that we have to take into account when we're looking at small n or single subject studies. So first of all, consider who's going to collect the data. These types of studies often take place, as I said, in institutional settings, hospital settings, that kind of thing. Sometimes in schools, sometimes in clinics or in an outpatient setting. But basically, is it going to be nurses, teachers, guardians, psychologists, the client themselves providing the measurements? So that needs to be taken into consideration because that's a factor in the validity and reliability of your measurement. Do those participants need to be trained as to how you would like them to record the behavior? Do you need to come in and make sure that everyone has the same connotation for the construct that you're measuring? So, right, you've operationalized it, but if you say staff injury, every staff member may have a different definition of what that is. So you need to be clear with individuals that are reporting it and say, this is what I'm specifically referring to, or this is the scale or the way that I need you to report this behavior. Measures should be as what's called non-reactive as possible. It should basically be as benign or innocuous as possible. If the measurement of the behavior causes a reaction in the subject, if it's aversive, or if it takes a long time, or if it causes them to stop what they're doing and have to do something else really for a long period of time, what you're seeing is that the participant may react to the measure itself and become less cooperative, start telling you what you want to hear to get through it quickly. It can introduce confounds into the study, essentially. You want to ensure that the measuring process is feasible. So whatever it is you're doing or you're asking nurses, teachers, guardians, psychologists, clients to do, it shouldn't be too time consuming, too cumbersome. It should be relatively brief. That helps to make it non-reactive. And the participants should be able to understand how to accurately report what's going on as far as the behaviors. Again, that's kind of back to training and making sure you clearly delineate how you've operationalized things. And then you want to consider the treatment sensitivity. As I said, if the behavior is really infrequent, it's going to be really difficult to study it using this type of repeated measures design because you're only going to have so few pieces of data. It's like, for example, when you study suicide, you don't typically utilize, suicide attempt as your only outcome measure, right? Because that's very rare. First and foremost, even amongst chronically suicidal patients, that's very rare in most cases. You might talk about things like suicidal thoughts. You might talk about, degree or increase of depression. You're going to look at things that are more feasible to measure and are more frequently happening, so you can look at other outcomes besides like this ultimate outcome you're trying to prevent. In Sam's case, you wouldn't want to measure just did he end up having to be seen by be hospitalized or taken to the ER because he hurt himself so badly. Did he require stitches, for example, right? That's a really infrequent and extreme dependent variable. You want to look at things that do occur and that the measurement is sensitive enough to pick up. So let's talk about some types of designs. The most basic design is an A-B design, and we're going to discuss all of these in detail. There are withdrawal designs where the treatment is administered then removed. There are what are called multiple baseline designs, and there are multiple treatment designs. We'll talk about all of these on their own individual slides. So the most basic design within a small n or single subject study is the A-B design. And this is essentially where there's a baseline phase with repeated measurements of the dependent variable, and then an intervention phase with continuing those same dependent variable outcome measures or target behavior measures. So what you've got is the baseline phase A and an intervention phase referred to as B. So the study we've been talking about with Bisconer and colleagues used this study. As I mentioned earlier, I believe they introduced the intervention as soon as they got the idea, but they did measure 3 months of the behaviors prior. I don't know if that was done retrospectively through the chart or if they actually had a period of time where they were measuring the behaviors, but they did 2 3-month periods. Section A was the 3 months of no intervention, measuring those 4 outcomes, those 4 behaviors they were looking at. And then section B was when the introduction of the behavioral modification program started, and they measured an additional 3 months of those same behaviors to see how effective the intervention was. So there are a couple of flaws with this design. It's simple and it's easy to understand, but it has some limitations because of its simplicity. Fluctuations are difficult to interpret, essentially. What happens is if there's a change in the behavior, it gets better, it gets worse, or it stays the same, we really don't know, is it due to our intervention alone, or is there some other extraneous variable that happened to come along at the same time, some other factor? So with that causality chain that we work towards, of temporal precedence, covariation, and then, of course, elimination of alternative explanations, the A-B design suffers on that third point. It's difficult to eliminate alternative explanations. Therefore, it's harder to establish an argument for causality. Now, we have an option. I apologize for how busy this slide is, but we'll go through it sort of more meticulously. Another option is to do what's called a withdrawal design. So if we can think of that initial design as an A-B design, there are 2 basic types of withdrawal designs. Now, these are not the only ways in which you can structure it, because you can do multiples of this, but we can basically think of them as an A-B-A or an A-B-A-B design. These designs are called withdrawal designs because the intervention is administered, concluded, and then temporarily stopped. Sometimes then restarted. Okay, we'll talk about what that looks like. But at some point in the study, the intervention is introduced and then it is stopped after a certain period of time. So there are some ways in which this can be really helpful, but there are some ways in which it can also be problematic. So there are a couple of potential problems we've got to consider if we're going to utilize an ABA or an ABAB design, a withdrawal design. The first is that withdrawing the intervention, the treatment, whatever it is we're doing, may pose ethical issues. If you're trying to stop Sam from, engaging in behaviors that put him or the staff in danger, then it might be unethical to remove that intervention if there's evidence that it's working. Okay, so that's one concern. The other is the intervention, whatever the treatment, whatever it is you do, the manipulation that takes place during the intervention phase, it may have a carryover effect, right? Especially when we're talking about modifications for behavior or psychology, clinical psychological approaches. We want the person hopefully to have some lasting change as a result of the intervention. We don't want it to only work as long as the treatment is present. But whatever you do, there may be a carryover effect. It may continue to influence behavior even though you remove it during the second baseline phase. So therefore, you have to try and examine whether or not there's a carryover or lingering effect. So let's talk about these ABA and ABAB designs and what that means. So if you remember from the previous slide, an AB design, A designates baseline phase where there's no intervention present, B represents the treatment or intervention phase where there is intervention present. So you can follow the logic. An ABA would mean that you start with a basic AB design, but there is a post-treatment follow-up baseline phase, the second A, where you essentially continue to measure the dependent variable. You might, in some of the design information in your book says you continue to measure until some pattern emerges. So it may just continue for a longer period of time than the other two sections even. But it provides some additional support for the efficacy of the intervention, because essentially if the client or the subject goes back to where they were, to pre-intervention levels, if they return to baseline, so to speak, it increases your argument that the reason why the behavior changed during the treatment phase was because of the intervention. So it supports the causality argument. What you're essentially saying is, like, the person was behaving this way, we introduced this treatment and they changed, or they got better presumably, and then we removed it and they went back to where they were. So it's starting to build more evidence for what's really covariation of cause and effect. When the cause is no longer present, the effect is no longer present, is what you're basically saying by that second baseline phase, if you get those types of outcomes. An AB-AB design, which what I alluded to, can be an AB-AB-AB ad infinitum. You can continue to introduce and withdraw multiple times, but the simplest form of this type of withdrawal would be called AB-AB. Again, starts as a basic AB design. You have this follow-up second A, the second baseline phase, and it again includes multiple measurements, and then you reintroduce the intervention. So by reintroducing the intervention and seeing that the same improvement or same change in the behaviors occurs, what you're effectively doing is replicating within your own study, right? You're showing replication of it. Again, this is more covariation of the cause as well. The idea that, the behavior is such in the absence of the treatment, then when the treatment, the cause, becomes present, the effect, the change in behavior shows up, then it disappears, and then it comes back. So you're just kind of showing that repetition of that covariation of cause and effect in an AB-AB design. So again, provides more argument. There's no guarantee that the effects will be reversed by withdrawing the intervention, right? Some things have carryover effects. They cause actual lingering change. And in fact, oftentimes we want them to. So you can't rule out the effect of other extraneous variables either. So even if the effect is not reversed during the follow-up, reintroducing so let's say that you introduce the treatment and then you go into the second A phase, you remove the treatment, and the person continues to do okay. Maybe they've stabilized, maybe they continue to get better. But when you introduce the second B, the second intervention, they do even better. So you might show there's an additive effect for this treatment. Receiving the treatment multiple times leads to multiple improvements. It's not that it only has a one dose efficacy. The more you receive of it, the more improvement you might see. So there's lots of interesting things you can learn, even within a small or even single subject design, by how you include or withdraw the intervention itself and what you can interpret based upon that. So these are graphs from a study by Kristen Ferguson and Margaret Rodway from 1994. So this is, they were basically looking at perfectionism as a trait, as a personality characteristic, and in some cases as an abnormal or quote unquote, a problematic behavior. Perfectionism, of course, is something that we all have some degree of along a dimension, but as is the case with a lot of things, being an outlier, being extreme, often can result in problems. So people that are overly perfectionistic will sometimes be diagnosed with something called obsessive compulsive personality disorder, which is very distinct and different from obsessive compulsive disorder. It's not an abnormal class, so I won't get into the details of that. But obsessive compulsive personality disorder could be thought of as extreme perfectionism to the point that it causes difficulty in being productive and being successful in your life. It can cause a lot of conflict as well with others. So the idea is this was a cognitive behavioral, meaning it targeted thinking and behavior and how they're related, treatment, a psychotherapeutic treatment for perfectionism. And so they had groups of people that were in this study, and these groups of people were basically, this was 9 clients, so a small n study, and they explored the effectiveness of the treatment. So this is an ABA design here. So in this first section, this is our first A section. This is the baseline phase before there's any intervention. All right, 4.5 weeks. Now what you'll notice is their treatment phase is not is longer, excuse me, than their initial baseline phase. One of the things we said earlier in an A/B design is you want these to be equal. My guess is that this is how long the whole study was scheduled for, and there were certain aspects. It's probably a 1, 2, 3, 4, 5, 6. It's probably a 7-session cognitive behavioral intervention that was delivered once a week or something like that, or multiple times a week, but maybe it's 14 twice a week. But regardless, there was something about the intervention that probably dictated this length of time, and this might have been as long as they had to gain measurement. But in a perfect world, right, you would want these two things to be equal. Anyway, this is the A phase, the pretreatment phase. This is the B phase when the treatment was introduced, and this is the second A baseline phase when the when the treatment was removed. These are some graphic representations of, excuse me, AB designs. All right, so this is the withdrawal design where the intervention is introduced, it's removed, and then it's reintroduced again. And these are, we were talking about what could happen in these cases when you remove it. So in this case, this is anxiety, and this is a class that was, this is from a study by Schutt in 2012. The process, it's from the book, actually, I'm sorry. But the idea is that the study itself is a class on anxiety reduction, anxiety management. And there was an intervention being introduced. So what you have here is the initial levels of anxiety, right? They're quite high on this scale. I believe is probably the BAI, the Beck Anxiety Inventory, right, which tends to give a scale from 0 to 30. So 25 range, 20, 23, 24. This is considered pretty significant severe anxiety. B is the treatment phase, so the intervention is introduced. You see much lower levels down around 15 to 10, which is mild. In the second A baseline phase, the multiple baseline phase that we see here, the treatment is removed and we see the anxiety starts creeping back up. And then in the second phase, the treatment is reintroduced and the anxiety is much lower. And in fact, you might say that this has an additive effect, right? There is a second possibility, which is an AB design where we don't see a reversal. So this is the initial anxiety, you introduce the treatment, but let's say that people continue to do well, that perhaps they had taken some lessons that were still present during the second baseline phase here, and they were doing well, and they got even better with the second intervention. So this is an example of how you can interpret graphical data in these types of withdrawal designs. There are some other types of designs that you see usually in small N studies as opposed to single case studies, but these are called multiple baseline designs. You'll see why that only makes sense for a small group rather than one individual in a moment. A multiple baseline study can be used for a variety of reasons. These designs allow you to introduce additional subjects, to introduce new target problems or settings to the study. One of the things that I think is interesting about small N, single case studies, and of course qualitative interviewing, qualitative research, which we'll talk about in a little bit, is that they lend themselves a lot more to adjustment on the fly, to which you might argue is not as scientific, and that might speak to the fact that these are often very applied clinical setting types of studies, but it is not considered inappropriate in these types of studies to add things along the way, or to try and maximize the effect somehow by introducing something additional, or saying, hey, this is working really well with this individual, let's go try it over there, let's go try it with these patients. You would imagine that in an experimental design, in more traditional large group studies, things are much more regimented and much more rigorous in terms of the structure. It doesn't really allow for those types of adjustments. One would argue that that could actually pollute the study itself. It's much more common to see this in single study, small N, and qualitative research, where you're adjusting as you go, or you're sort of like introducing new subjects or introducing new settings along the way. So what you get is a multiple baseline design where people are starting at different times, or you're having a longer baseline period leading up to the intervention being introduced. So the term that your book uses is concurrent multiple baseline design. The unique feature of this design is that the length of the baseline phase is staggered. We're going to look at an example of this in a moment, to control for external events across 3 cases, in this at least 3 cases. So the idea is, like, what if something happened just in the culture at that moment in the facility, regarding the weather, who knows, right? Some world event, whatever it was that happened that could have somehow influenced the outcome. So the idea is that the baselines they start at the same point, but that they are different lengths. And you'll see this graphically in a moment. And um, this can allow you, as I said, to introduce more clients, more target problems, more settings, that kind of thing. An alternative is what's called a non-concurrent multiple baseline design. And this is where you also have different lengths of time for the baseline period, but people don't necessarily all start at the same point of measurement. You can sometimes randomly assign participants to wait 3, 4, or 5 weeks to start. It can be used across different target problems. So you might have one client with a certain target problem in one setting, and then one client with a different target problem in that same setting. So one person is engaging in self-injuring behavior, and we're saying, hey, what if this also works for aggressive behavior? Let's try it with them. Different target problem. Or different settings. This is working really well on the locked unit. Let's go try this intervention with patients on the unlocked unit, where people have more freedom, where they're considered less acute. Let's go see how it works over there. And that's a way that you can be more flexible, and you can introduce these things as you go. So these are some examples of a multiple baseline design. In this case, we've got 3 different clients, participants, client A, client B, and client C. They all begin measuring the behavior at the same point on day 0, right, or day 1, I should say. So this one has a baseline of 4.5 days, this one has a baseline of 8.5 days, and this one has a baseline of 12.5. It's staggered. The idea being that if we all started at the same time, there might be something about what's going on with these patients collectively in the facility, whatever, historically that's going on. By staggering the baseline, what you're saying is that there's nothing that you're removing one alternative explanation in a sense. The way this is often done is these are behaviors that are being measured anyway. These are things that are documented in charts and target charts. So you sort of say, hey, this is starting to show some improvement with client A. Let's go try this with Mr. Smith, and you see that Mr. Smith is also benefiting. Hey, you know what? Mr. Jones might benefit from this too. Let's include him. And you see consistent improvement in this case. There are also what are called multiple treatment designs with single subject or small n studies. And this is where the nature of the intervention itself is going to change in phases throughout the study. And this can be really interesting when you have a treatment. Most psychological treatments these days, don't include one aspect only. They often have lots of skills, trainings, modules, things built into them, right? So, for example, treatment for panic disorder, people who have panic attacks sort of out of the blue and they struggle with them. You do training on diaphragmatic breathing. You do a lot of what's called psychoeducation about what's going on inside your body that results in panic. You might utilize relaxation, imagery, meditation, mindfulness approaches. So you're maybe giving them a whole set of tools to use. So the treatment might have lots of aspects to it. What you can do is you can sort of add those aspects or introduce them each individually, one at a time or collectively, and show this sort of convincing argument for the nature of the treatment program about how it works. So you can change things like the intensity of the intervention, right? You may start off giving clients, sessions once a week, and then you move to twice a week, or vice versa. You might start off more intensely 3 times a week, and then move to once a week or once a month or every 2 weeks, as a way of showing the person can sort of be weaned away from intensive treatment. So the intensity can change, as I said, the number of treatments, or even the nature of the intervention. You can introduce new aspects. Paul Beer and his colleagues in 2004 developed what they termed an A, B, BC, BCD, BCD design. This is for a single subject study with a participant they refer to as Ed. He was having multiple behavioral challenges, kind of similar to Sam. And what they decided to do was introduce all 3 aspects of the treatment sort of successively. So you have the A, baseline phase, you have the B, where you introduce one thing. In the BC, you continue that thing, but you add an additional factor, and so on and so forth. And we'll look at this in just a moment. It's a complex research design in a certain way, even though it's a single subject one, because it gives you a convincing picture of how the treatment sort of builds effectively with Ed over time. And it gives you a more complete analysis on the effect of these different aspects of what they call differential reinforcement for Ed. So what you're seeing here with Ed is 4 targeted outcomes. percentage of time engaging in self-restraint, percentage of time manipulating staff, percentage of time, I'm sorry, not manipulating, he does digital manipulation, percentage of time in slapping himself, percentage of time engaged with his work. So these are all different for target behaviors, target issues that they're targeting as far as dependent variables, outcomes go. And then if you look here, what happens is we have this A baseline phase, right? That is our baseline measurement of all 4 of these behaviors. And then you have the B, which is that they introduce one aspect of the intervention. They introduce reinforcement for engaging. He receives positive reinforcement for engaging with his work. And then they measure all 4 outcomes during that B phase. They continue the reinforcement for positive reinforcement for engaging. And then but also they include some whether or not he's rewarded as well if he does not engage in any slapping behavior, which is one of his self-injuring behaviors they were trying to address. They then go on to the BCD phase, which is they reinforced for engagement with no slapping, positive reinforcement for engagement, reinforced for no slapping, and then also no manipulation, which is sort of a nervous tic that this patient has. So again, you measure all 4. And then finally, what they did was they took this intervention and they applied it not only in his workplace, but in his community-based site as well. So they sort of intensified the intervention. So what you have is an A, B, BC, BCD, and then a slightly different, maybe asterisk BCD phase here. But it allows you to see the collective impact that this behavior, which is positive, you want him to do more of this, gets better. All of these other problem target behaviors go down in intensity. This one has a lot of fluctuation here in the last phase. But anyway, what we see here is a general trend of things getting collectively better as each aspect is introduced. So once we decide that it's appropriate or it's the right situation for us to use a small N or a single subject design, how do we interpret or analyze the results? We can't utilize the thing we most typically use in other types of research, which is inferential statistics, right? We don't look at means or central tendency or any variability because there is none, or there may be very, very small amounts of it within a small group, which we have to be very careful about interpreting. We're really, even in a small N, we're not so much looking at the mean across. What we're looking at is how each individual did. We're still treating it in many ways as a single subject design. We just are running them in parallel with multiple subjects. You might think about it that way. So in most cases in this type of design, like I said, this is often utilized in treatment settings, in interventions, in psychiatric or hospitals, that kind of thing, psychiatric centers, residential living centers, that kind of thing. Sometimes in workplaces though. We're concerned mostly about the client's status and whether the intervention is making a difference, especially if we're targeting potentially dangerous or harmful behaviors. If the intervention seems to be making a difference, then you tend to continue the intervention as needed. If it's not leading to meaningful change, then you alter the program. So as I said, it's not about necessarily publishing this study and changing how people do their own interventions out there in similar settings or in different settings. That's useful and that's great, and that's one of the values of this type of research. But we have to remember it's usually targeting a small group of people or a single individual, and that's really what guides analyzing the results. Does the person seem to be getting better in terms of these measurements of this behavior? What we typically do is we visually inspect the graphs, like we sort of did a moment ago with some of these figures from your book. This is the most common method for evaluating the data, is to graph it and inspect the visual display. We'll talk about that in a minute. Now, of course, you can do little manual graphs by hand. You can utilizing graph paper and a notebook as you're taking notes in the setting. But of course, we typically tend to use statistical software and spreadsheet software that present the data in graphs for us. There's some examples in your book of how to sort of utilize things even like Microsoft Excel to create really interesting graphs about single subject style designs that you can look to that reference in your book. The overriding issue, though, is often really practical clinical significance of the findings. We're not really talking in the normal language of statistical significance that we discuss in more traditional large group studies. In this case, we're much more focused on the impact on that individual or those small group of individuals. So we're looking for practical clinical significance in the findings. Does it really change their quality of life? Does it improve their safety or their health? So in a sense, has it made a really significant, meaningful difference in their well-being, perhaps according to the set of success that are these criteria for success that are set by the client, by the community, by the institution, that sort of thing. So let's talk about how we go about actually analyzing this data visually. So we look at the graph of the data points to determine if the intervention altered their sort of pre-intervention pattern of scores, right? Does the B phase look different from the A baseline phase? We can often look at this utilizing three basic guides to visual inspection: level, trend, and variability. So level is the magnitude of the target variable during treatment as compared to the magnitude at baseline. Is it higher or lower? Typically, this is used when the observations fall along a relatively stable line, when there's not a lot of fluctuation. It's clear that this is the A and this is the B. Then we see this significant drop in magnitude, which represents a change that could be very meaningful practically. Of course, the other issue is that if there's a lot of fluctuation in both sides, it's harder. We have to then start to look more at trends. This is the direction or the pattern of the data points, the slope of the line, if you will, on a typical XY graph. If the direction of the data did not change, did the rate of increase or decrease change, right? Did the slope, even if it was still going up, did it start to stabilize or taper off? And is it going up at less of a significant degree, for example? If you look at some of the data on Sam's behavior, his aggressive behavior after the baseline period really falls off very significantly. And then finally, we want to look at variability. So how different or divergent are the scores within the baseline and intervention phase? Maybe what's happening is not that you're seeing a massive slope change, a trend, but you might see that things are less intense, right? Less highs and lows. And we'll talk about variability and range bars in a minute. Let's go through some examples of these visually. So the first is level change. We're looking at this sort of magnitude of change across a period of time. As you can see, in the A phase of the measurement of anxiety, the general feeling is that line is significantly higher than the subsequent line in the B phase. Is there a change in magnitude? Of course, what you can do then is just take the mean across each of those, and that gives us sort of a flat line that we can much more easily compare for level change. And then, of course, what you often have sometimes with these examples are you'll have a mean line, but you'll also include a trend line. And if you notice, what's really important about this second one is the straight line here is the mean, right? And if you compare just those straight lines, they look identical. Okay, that's a problem of only looking at one aspect of the data visually. If you look at the trend is going in a very significantly different direction. In the B phase, it's decreasing as it was in the A phase. So we kind of want to be careful about how we interpret data. We have to make sure we look at different aspects of it from different angles. This is the measurement of Sam's behavior that I mentioned. I think it's pretty clear from the trend line that these self-injuring physical aggression towards others and towards self are both getting significantly better, and in fact dropping off quite quickly as the intervention is introduced, and then stabilizing at a pretty low frequency depending on the metrics they're using. I also mentioned the idea of interpreting based on variability or range. In this case, the mean of these behaviors might be relatively similar. You might not see a massive change, but what you will see is that the intensities, the highs have been cut off of the scale, right? The lows are about the same, but you're not seeing as many intense examples of the target problem here after the intervention, which is another way to interpret some degree of success. So those are all examples of how we interpret these. I kind of talked about this slide already in terms of interpreting them. These are some typical baseline intervention patterns, right? Again, this is just more examples of how we interpret things. So you see here we have a stable line, and A, B, and C. In case A, it's improved. In case B, it's about the same. In case C, the magnitude has gotten lower. We talked about stable lines versus trends. In this case, things are all kind of like hovering around this mean, but in case D, you're seeing that the behavior, the anxiety is increasing. In this case, in example E, it's getting significantly better based upon this trend. And then finally, there's different types of trend patterns, right? So in case F, this trend is just continuing upward. The slope is equal here. In G, it is still going up, but at less to a degree. In H, it has stabilized into a plateau, and in I, it is declining. So these are all visual patterns we can look for interpreting this data. So there are problems associated, as there are in all cases. There are biases or errors we can commit in how we interpret this type of visual data, and we need to talk about some of those errors to be mindful of. Patterns can be quite ambiguous, so making conclusions from visual inspection is less certain than being able to utilize inferential statistics. Um, the less points of data that you have, the more ambiguous these patterns can be. The more data you have, the more you can rely on this being a valid pattern. Widely discrepant scores in the baseline, if people are way up and down on the target behavior at the baseline, can make it really difficult to interpret any pattern that emerges during treatment. We have to be concerned about the idea of delayed change. Maybe what we're doing is working, but it takes a long time to show impact. You know, let me give you one example. Typical antidepressants these days, starting with Prozac, the selective serotonergic reuptake inhibitors, the SSRIs, some of the modern ones like Lexapro, Celexa, those types of things. Those are in the same family, slightly different. Those types of drugs, when given for depression, often take at least 2, if not 8 to 10 weeks to really start showing an improvement in the depression. There is a black box in the brain we do not fully understand, but we know that the serotonin levels and the norepinephrine levels in the later, more modern ones, those levels change almost within 24 hours overnight effectively. But there is a neuromodulation effect going on. It takes a while for people to actually feel better. It's why we always encourage patients who are being prescribed those medications, you need to take this for a couple of months to really see if it's going to work. Don't expect the changes right away. Unfortunately, you get the side effects for some of them right away. And so that becomes a barrier. The reason why I bring this up is that there's a delayed change. If I only measured the first 3 weeks or 2 weeks, I probably wouldn't see any effect. If I was understanding of that delayed change, I might extend out my assessment period, and then I might see this. But sometimes whatever you do, it might take a while for it to stick or for it to really show up in terms of change, and it might be outside of the window that you're assessing. The other is the problem of how graphs can be distorted, both intentionally and unintentionally. Graphing something and the choices that we make, the potential biases and error that we introduce by virtue of those decisions, can make for a very different interpretation of the same data. So how we graph can create visual distortions that can lead to very different conclusions. I'm going to show you an example in just a moment. The scale that you use on either axis, being very large or very small, can certainly exaggerate or hide relevant changes. So it's important to make the axes as proportionate as possible to minimize distortion. Do your best to make sense, to make them relatively proportionate to one another. As a general rule, of course, the more measurements taken during the baseline phase, the more confident you can be in interpreting the pattern. But let's look at an example of distortion. Oh, I'm sorry, this is an example of delayed change. I apologize. So this is one where during the A phase and the B phase, you see some increase for a moment and then some improvement right away. In this one, if you only measured for a short period of time, it would actually look like it was getting worse before you would see the improvement. This is an example of the distorted picture that I wanted to mention. This is the exact same data. What you'll notice is different. The number of days of the week, the x-axis stays the same, 1 through 7. But what you notice is the scale on the y-axis goes from including 0 to 30, 0 to 60, or 0 to 100. These are the exact same points of data. If you were to look at it on this scale, you'd say, well, this is a relatively erratic up and down sort of pattern or trend. This person is fluctuating pretty significantly in terms of this measure. If you look at it down here, you'd say it's extremely stable, right? Very little fluctuation. Same data, different scale. So those are important choices that you make in terms of how that's going to be visually interpreted. Ultimately, the big criticism that must be in your minds or must be thought about when we think about a single subject or a small N design is, does it have internal validity? Can we establish a good argument for cause and effect between these constructs, not just in this individual, but between these constructs in the real world? Because that's essentially what we mean when we talk about internal validity. The more measurements you take, the more confident you can be in the pattern. I've mentioned this already, so I'll just emphasize it once more. The more points of data, the better. There are problems like maturation, instrumentation, what you're using to measure. Is it sensitive or too sensitive, sensitive enough or too sensitive? Statistical regression to the mean, testing effects, sort of the reactivity of the test itself. You can try to control this by repeated measurements, but these patterns are illustrative, if you see them, to threats to internal validity, and they should appear in the baseline. Repeated measurements in the baseline phase does not control for a historical event, something that's extraneous, that's an alternative explanation that comes along that occurs between the last baseline measurement and the first intervention measurement. In that tiny window, there's lots of other things that can happen, and those other things happening just at random are controlled for in studies that include large samples. That is a smaller bit of noise. It provides less distortion if you've got 150 or 1,000 or 10,000 people in your study. When it's one person, when it's 3 people, massive impact. So that is a threat to internal validity in these small studies where you can't eliminate the alternative explanation. Therefore, you can't make as good an argument for causality. What about generalizability? There's an issue of representativeness or drawing generalizations to broader populations rather than it's really an issue of generalizability. So to demonstrate the external validity of a single subject design requires replication, right? Of course, we know at this point in this class, if you want to make an argument for generalizability or external validity, you point to replication. You have to replicate both the research conditions and you have to go beyond the research conditions to different settings, different targets, different aspects of the behavior or different subjects, obviously. And so therefore you can then start to make an argument for generalizability if you see replication. David Barlow, who's a giant in the clinical psychology normal world, and Michael Herson suggest 3 sequential replication strategies to enhance the external validity, the generalizability of a single subject design. They call that direct replication, systematic replication, and clinical replication. The first is to take the exact same study, the same intervention, and do it with different clients. Okay. If it's in a hospital or an institution, other clients, other patients within that same hospital institution. That's a direct replication. If the same results are achieved, the findings are thought more likely to be externally valid. Then you take it and you do the same intervention in a different setting, a less intense psychiatric setting. You go from the locked unit to the more open unit to the more stable unit or the outpatient setting. If you then take it to a different setting and the same results are achieved, you have, again, increased argument for external validity. And then finally, clinical replication, which is where you sort of combine these interventions into a clinical package and take it out into the real clinical world and intervene mostly in an outpatient setting. And again, if you start seeing the same consistent results with individuals, you can start to talk about the increased external validity based on this clinical replication. So finally, let me give a few quick conclusions about these types of designs. They are useful and they have their place and they can be very appropriate. They're good for evaluating practice. They're excellent for monitoring individual client progress. So this type of research sometimes crosses over into the clinical world where it's research that's being done systematically that you may have no intention of ever publishing, right? It might just be purely for the purpose of scientifically examining the progress of a single client or group of clients. It can make a really unique contribution to our clinical practical knowledge. And if you do it systematically, the success or the failure of different evaluations and interventions, the success or failure of different interventions can be evaluated with really distinct clients under different settings and conditions. You can statistically analyze this data. It just doesn't fall under our general umbrella understanding. When we think of statistical analysis, we often think in these days of large groups looking at central tendency and variability and doing inferential statistics that give us statistical significance. That doesn't mean that it's not valid or viable to look at this type of data statistically in the way that is appropriate for small N or single case study designs. And we do this graphically by visual inspection. And we also know that single subject design can be really helpful in examining the process of change and how it varies across particular clients. That can be extremely helpful for informing clinical work.